your faces here with us today. And I'm super fired up to get to be here with my dear friend, Charmaine. Charmaine, how's it going?
It's so good to be here. So excited for today. Thank you all for joining us.
Yeah. Well, we don't want to waste any time. We are racing against the clock now for the 30 minutes. Would love to hear if anybody has a case that they want to present for us today. Doesn't have to be prepared or perfectly polished. Any case is a great case. I have to imagine that there's one out there somewhere lurking in the shadows. Give people a few more seconds to think. All right, Nikita, thank you so much. I saw a subtle smirk coming across your face as you were thinking, and I was like, I'm gonna hold out and see if she'll have a case. Thank you so much, Nikita. Why don't
No problem.
Do you mind? I know many of us know you from your incredible cases and absolutely brilliant reasoning. But for those who haven't had a chance to meet you yet, do you mind introducing yourself?
Yeah, no problem. I had a smirk just because I was wondering whether it could be discussed within 30 minutes, but I think we can do it because I saw this case in an ER setting. So I think fast discussion is what we're going after today. But yeah, hi, I'm Nikita, and I'm G from India, and I recently graduated from MBBS, and I've been around CPS always for a while now, and I enjoy it. So I hope to have a good time with you all with this case that I'm going to present today.
Amazing. All right. Well, we will let, I think, Shema, are you scribing? We'll let you take over the whiteboard. And then Nikita, why don't you go ahead and get us started?
Sure thing. So the chief complaint is loss of consciousness and abnormal behavior. So let me give a background about this patient. So this patient is a 76-year-old man, and the patient was brought by his neighbor. So the neighbor found him unconscious on the road outside his house, and he doesn't know what happened, but he tried waking him up and he regained his consciousness. But as soon as he regained his consciousness, his responsiveness didn't seem normal to him. So after this, the neighbor brought him to the ER, and at the ER, he had 2 episodes of MSS. And when I did look at the vomitus looked clear. It was kind of speckled, but almost clear. And apart from that, he did seem conscious, but he was not oriented. And the neighbor said that since the time he tried to wake him up and after he regained his consciousness, he has had labored breathing. So should I go into past medical history?
We can just quickly pause here, Nikita. Thank you so much for presenting such a fascinating case. And I'll take a stab at some of it and then leave the rest for the amazing Dr. Penner. So I think just taking a step back and thinking about the loss of consciousness, a loss of consciousness in general, it's quite broad, right? It can be anything from somebody who is pulseless to someone who has like transient loss of consciousness, someone who had a fall and then hit his head and got altered. So I feel like that umbrella is quite big. And the the most reassuring things, like whenever someone is like laying there and they're not conscious, is that their ability to regain, because at least like they have a pulse, they're breathing because they were able to communicate you for a little bit. So I'm more thinking about it whether this is like transient loss of consciousness with some altered mental status, or is this patient just we need to investigate a little bit more of our altered mental status bucket. But the transient loss of consciousness, I think like syncope, seizure are the ones that I think of, especially like with seizure, having a little post-ictal phase that patients can be altered. However, things not to forget is that, a mechanical fall that that can have a head trauma that can cause people to be altered as well. So kind of thinking about that as well. And then figuring out how much we need to delve into our altered mental status bucket. The easy things that, we think of like right off the bat if this patient is presenting the ED is like, hypoglycemia, just making sure the sugar is like thing to check. There are so many times that, I walk into kind of the altered mental status, loss of consciousness, and as a resident, I forgot about hypoglycemia. So now I train myself to be like, oh, this is something that we can quickly fix. So it's something to remember. So I'll pass the mic to Jack to add some of his thoughts.
Oh, Charmaine, that was absolutely fire. So much ground covered and so efficiently. I think, the only other thread that I'm sort of grappling with in my head right now is what to make of this labored breathing that Nikita just sort of snuck in there. And I think in a case like this, where the dominant features of the case that we have so far are centered around something related to one's neurologic status, right? Consciousness and mental status. The labored breathing is very likely to be a consequence of whatever is driving the loss of consciousness or the altered mental status, right? One really easy way we can connect those dots is through an aspiration event. If somebody had a loss of consciousness, or if they're not able to effectively protect their airway in the setting of their acute encephalopathy, it's very easy for somebody to aspirate. And then that can cause what can sometimes be a very prominent aspiration pneumonitis, which can manifest as labored breathing. The other thing to throw in there in terms of something that could be driving the labored breathing is that it actually could be a signature of something happening metabolically related to the altered mental status, as Charmaine mentioned. For example, a profound acidosis can lead to alterations in one's level of consciousness and manifest as labored breathing as well. So I think a key thing to understand is whatever hit this person's brain, is the consequence of that what's happening in the lungs, or is the lungs another symptom of something that could be that could be happening more and more globally? But I think likely it's at this point where we have to falsify the common hypothesis, which is loss of consciousness led to an aspiration event. So Nikita, we'll turn it back to you to take us forward here.
Yeah, so in terms of past medical history, he was a previous farmer, but as of now, he's a sedentary man. He's known to have hypertension and type 2 diabetes since the past 40 years, and he's on medications. And he's been on and off in terms of medications. The reason why the neighbor knows all this is because the neighbor used to accompany this man for his clinical visit. So hence all this info at that point of time when I got. Apart from that, in terms of social history, in terms of health-related behavior, he's a known smoker since the past 40 years. He does consume alcohol in the weekends. He enjoys 60 ml of whiskey. And apart from that, he doesn't have any other medications. Is unknown at this point. The neighbor did not know the medications he was on. I'll jump on over to the physical examination. On physical examination, he's a poorly nourished person, and he was not alert and oriented to time, place, and person. His heart rate is 142 beats per minute. His BP is 70/50 mmHg. His respiratory rate is around 40 cycles per minute. His temperature is 38.9 degrees Celsius. His saturation is 89% on room air. Okay. Upon head-to-toe examination, his eyes, he had pinpoint pupils and they were not reactive. There was bleeding present in his gums. He had another episode of emesis, and at that point of time, there was blood present in his emesis, in his vomitus, sorry. Apart from that, he had swelling in the left lower limb up to the knee. Am I missing anything? Yeah, he has purpura present bilaterally on his lower limbs. He had a few ecchymotic patches on his back. And at that point of time, we had placed a catheter and there was no output. Okay, systemic examination, CVS, cardiovascular was within normal limits. Respiratory system, he had, his breath sounds were heard and he had diffuse crackles in all his lung fields. Per abdomen was within normal limits. And in terms of CNS, he was pretty rigid, but we couldn't really perform all the tests because he wasn't entirely responsive. So yeah, I think that's a good place to stop.
All right. Well, this the case has really opened up here, and I think that honestly, at this point, I feel like there's really more questions than answers. I think some of the things that are predominantly jumping out here, or that is changing our initial approach, is that while our initial dominant focus at the beginning was on the altered mental status, there's so many other features now that are dominating the clinical picture that make me think that the altered mental status is going to probably have to take a bit of a back seat as we figure out what's causing this vast number of other findings. Right? We have fever, we have tachycardia, we have hypotension, we have hypoxia, and then we have these very interesting exam findings with both features of a coagulopathy like bruising or bleeding, as well as purpura here as well. I think in terms of what exactly we can make of some of these possible exam findings, I think we have to sort of operate under the hypothesis that this person is infected and has some form of hemodynamically significant infection, right? Acute fevers, hypotension, and tachycardia is always going to lead us to prioritize understanding where this person could be infected first. And then we have to ask ourselves, well, what types of things could be driving this infection, right? And that's going to be really localizing the organs that could be involved. We have some signal that the lungs could be involved. We also have some signal that the vasculature could be involved as well. For example, the finding of purpura makes me wonder about either an underlying vasculopathy and or the presence of an underlying coagulation abnormality. It's very easy initially to link coagulation abnormalities to severe infection through the bucket of disseminated intravascular coagulation, right? DIC can cause easy bruising and bleeding, and occasionally can also cause abnormal vascular findings on exam like purpura, right? And so I think that for here now, the dominant element of my finding is going to say we have to look for a potentially severe and life-threatening infection, whether that is a severe pneumonia in the lungs, potentially something that can cause a disseminated infection with vascular abnormalities. For example, disseminated meningococcemia can cause something like purpura fulminans that can manifest with hemodynamically significant abnormalities as well as underlying vascular abnormalities. And then if we close the infection bucket, we might start to move on to other findings of inflammation, things like malignancy or underlying autoimmune disease, because we certainly have findings that could lead us down the autoimmune pathway, right? Purpura plus renal failure could be related to an underlying vasculitis that could also involve the lungs. But I think it would be inauthentic for me to entertain those hypotheses now until we've ruled out the infection bucket, given how systemically ill this person is. So where do we go from here? I'm curious to hear what Charmine's has to say, but I think it really is the hunt for sort of localizing where this infection could be coming from, if there is one.
Love that, Jack. Yeah, I feel like, somebody who's coming in with like hypertension, like inflammation, then like infection, definitely an acute one is high on the differential. If you ask me, like, there's so many reds in this part of the board, right? What am I going to be the most worried about is the blood pressure. especially in someone who has history of hypertension. So I assume this person's blood pressure lives much higher and his 70s to 50s. So if I'm like seeing this person in an emergency room in a rapid response, the first thing I'm gonna think about is that hypotension. And we like Jack astutely talked about like the distributive bucket, right? Is this like sepsis that we are worrying about, but also like thinking about your exam findings that could, if this patient is hypovolemic, or thinking about like cardiogenic bucket and obstructive one, that is something that I'm a little worried about. If this patient has with the left lower extremity a swelling, is this like a DVT? Jack beautifully mentioned that kind of seems like there's something up with the coagulation cascade. And thinking about like, hey, if this patient is having had a massive PE of some sort, that would explain the lower extremity edema, the tachycardia, the hypotension, the hypoxemia. So that's like one thing that I'm thinking about. So in addition to getting your basic labs, thinking about whether this is a patient that I'm going to scan sooner than later. And I think in terms of like a volume status, it's quite helpful. There's like there's diffuse crackles, which kind of points toward away from a PE if there's like a parenchymal involvement. However, with the coagulation cascade, I'll just keep that in mind as well. And I didn't hear a JVP exam, but that would be helpful if you think this person is hypervolemic. So I think a set of basic labs on thinking about your coagulation cascade with the purpura present, palpable purpura is quite helpful, and the differential is quite limited. The purpura itself, it just kind of tells you there's like bleeding and thrombosis, like erythema that is non-blanchable. So clots can do it, bleeding can do it. So I think just additional information would be quite helpful.
Yeah, that was a great discussion. Hang on tight for these labs because there are a lot. So I'll go slow. Hemoglobin was 6.5. His WBC count was 16,200. His platelets was 80,000. His INR was prolonged. I don't really remember the value, but his INR was prolonged. So as his APTT, that is activated partial thromboblast time. In terms of electrolytes, his sodium was 135. His potassium was 6. His chloride was 110. Bicarb was 12. In terms of his ABG, his pH was 7.32. His PCO2 was 24. And his PO2 was 83. Other values, his serum urea was 213. His creatinine was 8.9. His uric acid was 7.2, serum uric acid, 7.2. At this point of time, his ESR was 20. His AST was 727. ALT was 528. His ALP was 420. I'm missing anything. Yeah, I think those are the labs for now.
Thank you so
Would you
much.
like me to, I'm sorry, would you like me to add the imaging too at this point of time?
I think we can pause here. We've given us so much to think about. Can I just ask you, if you don't mind repeating the creatinine? Was it?
Yeah, his creatinine was 8.9.
Okay, all right. Whoa, all righty. So we have someone who is quite sick. So the name of the game is like stabilizing and then figuring out what we need to address. So I'll start with the CBC and then pass it along to the wonderful Jack to think through the rest. So from that CBC alone, if we have elevated leukocytosis, it would be helpful, but let's just pretend it's neutrophilic predominance. That again, make us a little bit more worried about inflammation and infection in particular. The one thing that grabs my attention is that platelets. Is that 8,000 platelets? This is quite low. Am I not missing the units there?
Yeah, it's 80,000.
80,000.
Which is pretty low.
Okay, great. Just wanted to make sure I'm not, the unit conversion has never been my strong suit. So thinking about, the thrombocytopenia itself, the things that I really worry about and hold my breath is that getting a smear to make sure if there's any schistocytes. So your MAHA's thing to worry about. If again, this patient is not someone that be worried about heparin induced, doesn't seem like he's recently been hospitalized. HIT and MAHAs are the two big ones that I think about, and especially in someone who's coming in with some coagulopathy issues. A DIC is the one to think about the most. Most causes of DIC are secondary, and thinking about infections in particular that can present with DIC, something that I'm really worried about that, especially with our worry with bleeding and clotting. So thinking about DIC high and then why this patient is on DIC. I'll pass along the mic to Jack for more of his thoughts.
Oh, Charmaine, I love it so much. I think just to be able to sort of distill it down to the core questions here just makes me so. One thing, it helps me a lot think about how to organize what feels like it's about to be a very disorganized discussion for me. So thank you so much for that. I think the question then becomes, how do we take the metabolic abnormalities that we have here and layer them on to the phenomenal hypotheses that Charmaine gave us in terms of how we can think through the CBC and some of the other coagulation abnormalities, right? And I think the question then becomes, well, what do we make of this profound renal failure? And I think the way that I'm thinking about this is, one, what is most urgent and life-threatening to figure out, and two, what is something that is ultimately plausible. So if we think about the things that are plausible here, right, DIC and the microangiopathic hemolytic anemias can be here. Of the things that can cause underlying DIC or a MAHA, which of them are the most urgent to think about? Well, TTP, HUS, and overwhelming infection leading to disseminated intravascular coagulation are things that are going to be most important to prioritize. And then the question in my head is, well, can those cause renal failure? Overwhelming infection? Absolutely. We can see multi-organ failure and renal failure in that setting. Can TTP cause renal failure? Absolutely. It's one of the findings that we may ultimately see. Usually encephalopathy dominates over the renal failure. And then the other thing that we can sometimes see is something like hemolytic uremic syndrome, right? All of these sort of MAHAs coalescing together. And that can also cause renal failure. Of those things, the one that we may be able to get the answer to the quickest is confirming whether or not there's schistocytes and then doing our best to find the infection. The infection evaluation, right, is going to usually prioritize organ-based infections first, common places like the lungs, a necrotizing skin and soft tissue infection, a really bad pyelonephritis. We don't have a lot of signal that there could be cholangitis. I think the AST and the ALT abnormalities are probably due to overwhelming illness. But then we get into the very interesting category of, well, is there a bloodstream infection that could be causing this? And certainly some bloodstream infections can lead to the development of DIC and underlying vascular abnormalities. We mentioned meningococcemia before, but we don't really see great risk factors for that here. But in reality, any overwhelming bacteremia, whether it's a gram-positive bacteremia like Staph aureus or a gram-negative bacteremia from an intra-abdominal or a urinary tract, can lead to the development of DIC. So again, I think it sort of is going to be falsifying the infection hypothesis first before we move on to these other findings. But certainly if we see schistocytes on the smear, we're going to put all of our energy into the infection bucket, and then also asking some of the challenging questions about the management of an underlying thrombotic microangiopathy, like do we start plasmapheresis alongside antibiotics? And so I think that really feels like the key crux of the case for me, because so many of the things that cause the diseases that Charmaine mentioned can also cause overwhelming renal failure, and it's hard to make much progress on the renal failure without understanding what's happening with the CBC.
those were amazing teaching points, guys. I learned so much from that. But I think we're in the right track. So I'd like to help with the diagnosis over here by offering you the chest X-ray, the CT head, and an ECG. So starting with the ECG, there was an ST segment depression, which was present in the anterior chest leads, that's V1 to V4. In terms of his chest X-ray, there was bilaterally there was patchy and diffuse scattered opacities. In terms of CT brain, there was punctal hemorrhages and brain parenchyma, which was not specific, but just punctal hemorrhages everywhere. Also, we're in the ER at this point, and everything was happening so fast. And I don't remember the specific part about the CT, but this is what I remember, there being punctal hemorrhages in the brain parenchyma. So these are the three imaging findings that I have as of now.
All right. Well, maybe I will talk about what to make of the EKG and the chest X-ray, and then I'll leave the brain imaging for you to take us through, Charmaine. I think, you know, the one of the things that's coming through my head is sort of how do we interpret ischemic changes in someone who's this sick? And I think the first place that my brain goes is that someone who's 76 years old has risk factors for underlying coronary artery disease, it's completely reasonable for them to have the emergence of ischemic EKG findings in the setting of acute illness. This is effectively their stress test that they're going under. So one hypothesis is that these ischemic changes are merely driven by underlying CAD that's already pre-existing and getting activated in the setting of stress. Right, but we've talked about this other potential etiology here, which is that we're seeing features of bleeding and potentially features of clotting as well with this this sort of focal unilateral lower extremity swelling. So is this ischemia actually a result of an intravascular coagulation process or an embolic phenomenon that could be happening here? In terms of the chest X-ray findings, right, again, when we see bilateral patchy infiltrates in somebody who's febrile, hypotensive, and tachycardic, the first place that my brain goes is that this person has an underlying community-acquired pneumonia. But opacities can be a number of things. So if they're not infection and we rule that out, other things that we can think about is edema, which could be related to underlying cardiomyopathy, which could also link into the brain findings that we have here, or it could be hemorrhage, right? We talked about the fact that a vasculitis could be an underlying explanation here, and sometimes we can see diffuse alveolar hemorrhage. But again, I think the focus is going to be on some sort of underlying infection, whether that infection started in the lungs and is now making its way into the bloodstream, causing all of these abnormalities, or it's actually a bloodstream infection that is making its way to the lungs in the form of something like septic emboli and causing multifocal opacities. I think we would need more information to figure that out, but also the head imaging and how we put that together could potentially come into play here. So I'll kick it over to you, Charmaine, for that part.
Yeah, I 100% agree. And I think with the CT imaging, for me, it's kind of more, it kind of points out the severity of this patient's illness, right? And for me, it's like kind of the extension of the coagulopathy that we've already noticed, right? Like the punctate hemorrhage. Like the question is like with the brain imaging, is it the sequela of an event, or is it like the primary driver? And for me, I'm kind of attributing it to as a sequela of what is going on in his blood. And I think like a fibrinogen would be very helpful here if you're thinking about like DIC and infection most likely. You know, I am still like kind of debating between slightly favoring DIC given to presentations, but like, you know, it's a good, usually like HUS is another one that you think about. With your smears, just if you don't see schistocytes, still think about DIC because it has like about 50% sensitivity specificity for that, versus like with HUS, CTB, more than 99% of the time you might see a schistocytes. So again, like DIC is the one that you want to still keep thinking about. And you know, with platelets, usually with like a TTP or platelets like less than 30K, you know, these are just kind of like general rules. However, like what we love about medicine is that medicine tends to break most of them. So I think at this point, I would love to see a fibrinogen. Infection is also high on the differential. And again, like any any traumatic event, any infection can set up DIC. So I agree with you, Jack, is that's my number one. It's like something that caused the IC infection being probably the most likely etiology. However, not losing sight of like kind of HUS as well, given that kidney function. The hard part is that AKI is also is another signal of something bad happening. Like if you're something bad happening to your in your blood, like you can get an AKI versus that a representation of HUS, or this patient is like super septic and has a really bad AKI. The degree of that creatinine makes me wonder about HUS. However, I am very excited to see. And Nikita, what do y'all thoughts?
Yeah, so before I could even send in labs, through the complete head to toe examination, we did see that there was just one limb that was swollen up. Yeah, it was his left limb. And when I did take a look at the dorsum of his foot, there was one point on his foot which was bleeding profusely. And at that point of time, I realized what has actually happened to this patient. So what you're seeing right now is a venom-induced consumption coagulopathy that has happened due to a snake bite. So a Russell's viper is a hemotoxic venom, which can cause a DIC-like picture, which causes a venom-induced consumptive coagulopathy. So the reason why you're seeing this patient to be in this state as of now is because of the fact that we received this patient 12 hours after the said snake bite. So this man had a snake bite in the morning, and I don't know if this is me being biased, but when it comes to Indians and snake bites, it's quite common, and people don't really do a lot about it. So this man thought, hey, it's snake bite, I'm going to be fine, and didn't really do much about it. But he quickly deteriorated in the evening, and the common snake that causes this picture is Russell's viper, since it's a hemotoxic picture right now. So yeah, this was a venom-induced consumptive coagulopathy. That's the case.
My mind is blown. I'm with you, Charmaine. Nikita, just for clarity, is the thought that the consumptive coagulopathy was DIC, and it was, rather than the common findings or the common reasons for DIC, this was basically snake bite venom induced disseminated intravascular coagulation?
So the thing is that in the ER, snake bite is one of the most common things that we always see. Yeah. So it's either a hemotoxic presentation or a neurotoxic presentation.
I see.
Funny enough, as soon as we had this case and I cleared out this patient from the ER, the next patient I had online was a neurotoxic patient. Wow. Neurotoxic snake bite patient. So yeah, this is very common, and we usually know, and this is the reason why I find head to toe examination really important, and it's very revealing in all kinds of cases, regardless of snake bite or not. So that one point of profuse bleeding with 2 fang marks that was present was very revealing of what was happening to this patient. So hence, we just had to, his symptoms were revealing enough to know that, yes, it is a hemotoxic snake bite. And then the labs just confirmed it. Yeah. Unfortunately, this patient did not make it. We got him in a really bad point of time. But yeah, this is very common in the ER.
Wow. Well, thank you so much for sharing that with us. Charmaine, I'll kick it over to you for any of the final reflection.
Nikita, thank you so much. What a fascinating case to think about. Your presentation was just so marvelous. And I'm so sorry to hear that this patient didn't make it. And thanks so much for sharing all the learning to us, because I've never seen a snake bite. But I think this case also emphasized why I'm so scared of snake bites. So I will keep trying to avoid snakes as much as possible. And it was just really great to think through and learn from you. And I think this is one of the things I enjoy so much about VMR, is that I get to learn from you all, our expertise and the things that you all see so much more than I do. So thank you so much. I really appreciate it.
All right, Madalena, take us home with the teaching points after this incredible case.
Yeah, Nikita, I just want to say that was such an incredible case presentation, and I was on the edge of my seat the whole time, and it was also a fantastic discussion. So I'll jump in with the teaching points. There were so many, I was running out of room, but we started off with loss of consciousness and potentially altered mental status. And just from the initial information, the loss of consciousness can be very vague, but the key finding was that it was transient. And with transient loss of consciousness, you can think of things like syncope, seizure, stroke, substances, hypoglycemia. When we got more information in the physical exam, our focus really shifted to stabilizing the patient and needing to rule out life-threatening infections. So when we were concerned of infection plus signs of coagulopathy, we first started thinking about DIC. When we looked at the vitals and saw that the patient was hypotensive, we thought of the big buckets of shocks, so including distributive shock like sepsis, hypovolemic shock, obstructive, cardiogenic. Moving on to the labs, this was a really meaty part of the discussion. So we saw the leukocytosis and the thrombocytopenia and immediately thought that we needed to get a smear to look for schistocytes to rule out a MAHA or DIC. But really important pearl is that DIC can be present even without schistocytes. And I think Charmaine taught us that the schistocytes are only present in around 50% of the cases. We also learned that most causes of DIC are secondary. And then we started incorporating information from the metabolic panel. We thought about both DIC and MAHA were plausible explanations for this. And then we were thinking what could cause renal failure, and this could included TTP, HUS, and then an infection leading to DIC. And then ultimately the imaging findings with ischemic changes, I thought this was a really great point that the ischemic changes could either, they could have been driven by an underlying CAD that was pre-existing, that was activated in the setting of the stress, or another etiology like the result of this intravascular coagulation process. So it was such a fantastic case, amazing discussion, and thank you all.
Madalena, crushing it like always. Thank you all so much. Nikita, amazing case. Thank you so much for all the wonderful thoughts in the chat. Jack, you're awesome. We'll see you tomorrow. Bye.
Bye, everyone.